I'm Patrick Wen. I direct the Center for Neuro-Oncology at Dana-Farber Cancer Institute, and I'm a professor of neurology at Harvard Medical School. And today I'll be presenting the current and future management of IDH-mutant low-grade gliomas. An important advance in the field occurred in 2021 when the WHO updated the classification of low-grade gliomas. It condensed all the different entities on the left to 3 entities listed on the right. Following this classification, all astrocytomas and oligodendrogliomas are required to have IDH mutation, whereas glioblastomas now no longer have IDH mutation and are IDH wild type. The IDH mutated tumors are divided into astrocytomas and oligodendrogliomas. These are relatively rare tumors. Oligodendrogliomas have an incidence of 0.29 per 100,000, and astrocytomas have an incidence of 0.45 per 100,000. But importantly, they occur in patients between the ages of 25 to around 50, and so have a significant impact in patients at the prime of their lives, and a significant impact on morbidity and mortality. Based on this classification, the tumors are classified based on the presence of the IDH mutation and the presence of 1p19q co-deletion. So those patients that are IDH mutated and have 1p19q co-deletion are classified as oligodendrogliomas and graded into 2 or grade 3. Those patients that have IDH mutation and intact 1p19q are termed astrocytomas and are graded into grades 2, 3, and 4. Those patients that are IDH wild type are termed glioblastoma and will not be discussed in this presentation. The first step in the treatment of all these patients is surgery. And a study by Jack Allard a number of years ago showed that those patients who had a surgical resection lived significantly longer than those patients who had a biopsy and were then observed. And so the standard of care for patients suspected of having a low-grade glioma is to have surgical resection. For every surgical resection, the goal is to have maximum resection of the tumor that can be formed safely. A study from Sean Hervey-Jumper and a number of colleagues at UCSF and some other centers showed that those patients that had a gross total resection lived significantly longer than those patients with a subtotal resection. But there is an important difference between the value of surgery for astrocytomas as compared to oligodendrogliomas. Those patients with astrocytomas, patients who had a gross total resection or even a supramaximal resection, did much better than those with a subtotal resection. Whereas for oligodendrogliomas, the benefit of surgery is much less, partly perhaps because these tumors respond better to radiochemotherapy. And therefore, when surgeons are considering resection in these patients, these data would support being more aggressive in those patients with astrocytomas, since they do better with a gross total resection. Whereas since the benefit of gross total resection is less for oligodendrogliomas, the surgeons can be more conservative, especially when eloquent areas are involved. Following surgery, the treatment for these patients is radiation and chemotherapy. Up until recently, patients were divided into high-risk and low-risk groups. Low-risk were considered to be those patients that had a gross total resection and age 40 years or less. These patients could be watched with serial scans, and further treatment would be implemented if there's evidence of additional progression. But for grade 2 tumors, those patients who had residual tumor after surgery or are above the age of 40 would be recommended to have radiation and chemotherapy, usually PCV for oligodendrogliomas and temozolomide following radiotherapy for astrocytomas. For grade 3 tumors, regardless of the extent of resection, the recommendation is to have radiochemotherapy for everyone. These treatments can be helpful. So, for example, for grade 3 oligodendrogliomas, the median survival is 14 years, and even at 20 years, 30% of patients are progression-free. And so patients can live for a relatively long time. The problem is that as patients live longer from the radiotherapy, usually after 10 years, they begin to experience significant cognitive problems from the radiotherapy. The scan shows a patient of mine who was treated 20 years ago for a bifrontal astrocytoma with radiation, and you can see the white matter changes. And although this patient has never recurred, she is significantly disabled and requires full-time care. And so it's important to try to develop treatments that have less long-term neurocognitive consequences, or at least delay the start of radiation and chemotherapy for as long as possible. In 2009, IDH mutations were identified as a key driver of glioma development. This is one of the earliest molecular drivers in these tumors. Under normal circumstances, IDH converts isocitrate to alpha-ketoglutarate with the generation of NADPH. In the presence of a mutant IDH, the alpha-ketoglutarate is converted to an oncometabolite called 2-hydroxyglutarate. This accumulates in very high concentrations in the tumor and leads to epigenetic changes in tumorigenesis. Vorasidenib is an oral brain-penetrant inhibitor of mutant IDH1 and 2, and the hope is that it would inhibit the mutant IDH and reverse this process and control tumor growth. Vorasidenib was studied initially in a first-in-man phase 1 study. The recommended phase 2 dose was determined to be 50 milligrams a day, and dose-limiting toxicities were elevation of liver function tests. In this study, those patients who had recurrent non-enhancing tumor appeared to have prolonged progression-free survival. In contrast, those patients who had recurrent enhancing disease, presumably indicating that these were more aggressive tumors with other pathways activated, seemed to benefit much less. To determine the biologic effect of vorasidenib and how well it penetrates the brain, a surgical window of opportunity trial was conducted. In this trial, grade 2 IDH-mutated glioma patients who were recurring and required surgery were treated either with no treatment for the 4 weeks, with different doses of vorasidenib, or different doses of ivosidenib, which is an IDH1 inhibitor that was known not to get into the brain as well. The patients were treated for 4 weeks, and then the patients went on to have surgery. The tumor was resected, and the drug concentrations and the ability of the drugs to inhibit the pathway was determined, and this was measured by lowering of the 2-hydroxyglutarate levels. So in this study, in IDH wild-type tumors, there was a low 2-HG level. This is a log scale. For IDH-mutated tumors that were untreated, there was high 2-HG. And with vorasidenib in blue, there was reduction in 2-HG by more than 90%. Ivosidenib, which doesn't get into the brain as well, but which can be given in much higher doses, also inhibited the pathway by more than 90%, although the inhibition was much tighter with vorasidenib. As a result of that study, vorasidenib was chosen to go on to a phase 3 trial called the Indigo trial. This was a double-blind randomized trial of 331 patients. The participants were those aged 12 years or above with grade 2 IDH-mutated gliomas who had had only prior surgery. They had to have measurable disease, which is more than 1 by 1 centimeter of tumor, and they were felt not to need immediate treatment with radiation and chemotherapy. These patients were randomized to vorasidenib 40 milligrams a day or placebo, and the primary endpoint was progression-free survival by blind independent radiology committee. There was a key secondary endpoint of time to next tumor intervention and a number of secondary endpoints, including tumor growth rate by volume, safety, and quality of life, as well as some additional exploratory endpoints. The two groups were balanced in terms of prognostic factors. But one thing I wanted to bring up was that 80% of patients had more than 2 centimeters of tumor. And by the old, outdated, low-risk, high-risk group, it means that 80% of these patients were in the high-risk group. At the second interim analysis, the study was stopped for efficacy, and the patients in the placebo group were unblinded and allowed to cross over to vorasidenib. The study showed that there was a significant prolongation in progression-free survival with a hazard ratio of 0.39 and a significant p-value. The time to next tumor intervention was also significantly improved in the vorasidenib group, and the median time to next tumor intervention was not reached in the vorasidenib group, whereas it was in 17.8 months for the placebo group, with a hazard ratio of 0.26 and a significant p-value. The vorasidenib group showed benefit in all the subgroups, including both oligodendrogliomas and astrocytomas. The second interim analysis, the data cutoff was in September of 2022, and the study was unblinded in March of 2023. This meant that there was an additional 6 months of follow-up that was not initially reported in the New England Journal paper. And so this data has now been analyzed, and the follow-up has been presented at the SNO meeting in 2024. So the median time of follow-up increased from the 14 months in the original report to 20 months. With this additional follow-up, the original results were confirmed and strengthened. The median time to tumor progression for the vorasidenib group is now not reached, and the hazard ratio improved to 0.35 with a more significant p-value. And similarly, for the time to next tumor intervention, the vorasidenib group, it was not reached. The hazard ratio is now 0.16, and the p-value is also increased. Because there was measurable disease, we were able to follow the tumor volumes. And here in blue, you see that patients in the placebo group showed continued tumor growth on treatment with placebo, whereas the patients with the vorasidenib groups stabilized, and then there was reduction in tumor volume over time. In a subset of patients, we were able to obtain the pre-treatment MRI scans. And so here on the left, you can see the tumor is growing on study, and on placebo, it continues to grow. Whereas in the middle panel, you see the tumor growing, and then after treatment with vorasidenib, the growth flattens and then starts to decrease. One of the most important aspects of this drug is that it is very well tolerated. And unlike many targeted therapies, most patients will tell the physician that they don't feel like they're on active treatment. So the quality of life is no different from placebo. However, the drug does have some side effects, the main one being elevation of liver function tests. And in 10% of patients, the uh, the dose has to be decreased, and in 3 to 4% of patients, the drug has to be discontinued. But apart from the liver function test abnormality, the patients have relatively few other side effects. And so it's a drug that patients can take for quite a long time. The 2-hydroxyglutarate level that's elevated in IDH-mutated tumors is thought to contribute to seizures. And so the hope is that vorasidenib, by reducing 2-HG levels, can reduce the frequency of seizures. In the initial report, there was no difference in seizure frequency between the vorasidenib and placebo arms. And this was probably because patients with intractable seizures were excluded from the trial. And so the rate of seizures was relatively low. But now with longer follow-up, the patients in the vorasidenib group had a significantly lower rate of seizures compared to placebo, confirming the hope that vorasidenib can have an anti-seizure effect. So as a result of this study, vorasidenib was approved in August of 2024 by the FDA for grade 2 astrocytomas or oligodendrogliomas with IDH mutations who have had only prior surgery. And they allowed patients not only to have a subtotal resection, but also allowed patients with a gross total resection. To put this in context, this is the first new treatment for lower grade gliomas since the introduction of temozolomide in 1999. So I think the field is now trying to understand the role of vorasidenib in patient management and where it is best suited. This is a recent review published in Oncology that discusses many of these issues. I think for most patients with grade 2 gliomas who have had a subtotal resection, the general consensus is that these patients should be treated with vorasidenib. For those patients with a complete resection, the options are to watch and observe them closely and treat only if there's further progression, or for treatment with vorasidenib. And for the group that are considered a high risk, they should be treated with radiation and chemotherapy. But the definition of high risk, I think, is evolving. With any treatment, there needs to be a balance between the risks and the benefits. And one of the strengths of vorasidenib is that because it is so well tolerated, apart from the liver function test abnormality, the risks are relatively modest. As I mentioned previously, patients who were under the age of 40 and had a gross total resection and no neurologic deficits were considered at low risk, whereas those above the age of 40 with a subtotal resection and other aspects, including neurologic deficits and large tumor size, were considered at high risk. But this definition is now no longer considered valid and has been removed from, for instance, the NCCN guidelines. And in particular, the 40 years age cutoff is not thought to be valid anymore. There have been a number of series of studies in both astrocytomas and oligodendrogliomas, suggesting that up until the age of 60, there is no increased risk of progression in these patients. Some studies suggest the risk increases above the age of 60, but then you have to be concerned about other competing factors in elderly patients. The other thing that I want to bring up is that regardless of the extent of resection, the residual tumor, even in those patients with gross total resections, are continuing to grow. It's not as if after surgery, the residual tumor stops growing. So they may be growing at a slow rate or they may be growing at a faster rate, but they're always growing. And this is an important factor to take into account when determining what additional therapy should be considered. So there are a number of clinical scenarios that the role of vorasidenib is being debated. One is, should vorasidenib be used in patients with gross totally resected tumors? In the Indigo trial, patients had to have measurable disease, but this is not because measurable disease responds better to the drug. We wanted measurable disease because we wanted to measure response from the drug and also to look at tumor volume growth rates. And we know that even patients with gross totally resected tumors have residual disease, sometimes a significant amount of residual disease. And so there's no definite reason why one should wait for progression before starting treatment. Another issue is whether patients should start treatment immediately after surgery. In Indigo, patients were eligible if they were 1 year to 5 years from the initial surgery. And the 1 year cutoff was mainly to exclude the very rapidly growing tumors. But patients could potentially be treated earlier. I think there is some debate about this, though. There's some tumors like oligodendrogliomas who, if they've had a gross total resection, may remain relatively stable for a number of years before tumor growth can be determined. And for these patients, some would suggest watching them, but others would think that earlier treatment is better and vorasidenib may be reasonable. Another factor is that these are patients in childbearing ages. And so especially for women, if they want to have children, this window after a gross total resection may be a window in which they could try to conceive. Another issue is whether vorasidenib should be used in patients with contrast-enhancing disease. We know that contrast enhancement, especially in recurrent tumors, correlate with tumor grade and outcome. And recurrent tumors with contrast enhancement respond less well to IDH inhibitors, presumably because they have a higher grade and have other pathways activated. But the significance of contrast enhancement in newly diagnosed tumors is less clear. Up to 50% of oligodendrogliomas and 20 to 50% of astrocytomas have contrast enhancement. And I think we feel that contrast enhancement in newly diagnosed tumors is of less importance, and that vorasidenib could also be used in these tumors. Another scenario are patients who've had a resection of the tumor. In this patient, they had a gross total resection and were observed for a period of time. But when the tumor recurs, the option is radiochemotherapy or vorasidenib. These patients were included in the Indigo trial, and so this particular patient went on to be treated with vorasidenib. Another issue that comes up often is whether to consider vorasidenib after radiochemotherapy. This is an oligodendroglioma patient that was not operable, had a biopsy, and treatment with radiation and chemotherapy. The role of vorasidenib in patients who've finished radiochemotherapy is unclear. There's a trial called the VIGO trial in the EORTC that is ongoing that will look at the value of vorasidenib or placebo as adjuvant after completion of radiochemotherapy. And this particular patient opted to receive vorasidenib. Another issue is the role of vorasidenib in recurrent tumors. And I showed in the initial phase 1 study, those patients with recurrent non-enhancing disease seem to benefit from the drug. A more controversial area is whether to use vorasidenib for grade 3 tumors. In the past, those patients with grade 3 tumors were considered much worse than those with grade 2, but this included IDH wild-type tumors. If you look at those patients with IDH mutated grade 2 and grade 3 tumors, the outcome is actually much less than most people realize. The top graph from MD Anderson shows no difference in outcome in these patients, and the lower two graphs show that grade 3 patients did slightly worse than grade 2 patients, but the difference was relatively modest. This review by Martin van den Bent and colleagues reviews all the data comparing grade 2 and grade 3 patients and came to the conclusion that in some patients with grade 3 tumors, if they're carefully monitored, it may be reasonable to consider the use of vorasidenib. For instance, a grade 3 oligodendroglioma glioma patient who's had a gross total resection. There's now a lot of interest in where else vorasidenib should be considered, whether it should be used in grade 3 and 4 tumors, or as adjuvant therapy after chemoradiation, or in combination with other treatments. The Alliance Cooperative Group is now conducting a trial that adds vorasidenib to adjuvant temozolomide after radiotherapy and comparing it to placebo. And this trial will begin later this year. And as I mentioned earlier, in the URTC, they are conducting the VIGA trial, looking at the addition of vorasidenib following completion of radiochemotherapy and comparing it to placebo. There's also a lot of interest in immunotherapies. There are preliminary data showing that vaccines are well tolerated and can generate an immune response, and these are being studied. And then the high 2-HG levels in these tumor has been shown to be immunosuppressive. And so if you can reduce the 2-HG levels with vorasidenib, you can potentially augment the immune response and combine vorasidenib with vaccines or with checkpoint inhibitors. So there is an ongoing study looking at vorasidenib with pembrolizumab in recurrent IDH-mutated grade 2 and 3 tumors. These patients are treated before surgery so that we can look at the tumor and see if the combination does augment the immune response in the tumor. And this is an ongoing trial. There are other IDH inhibitors that are also being studied. Olutasidenib showed in the phase 1 study that there is activity and is being studied in pediatric brain tumors, and there are other studies being planned. And then another IDH inhibitor, DS1001 or safusidenib, was shown also in a phase 1 study to have responses even in enhancing tumors, and additional studies with this agent is also being planned. So I tried to review for you the development of IDH inhibitors for IDH-mutated lower grade gliomas. I think this has changed the treatment landscape for these tumors. And because it's so well tolerated, I think it's an important advance for patients. However, the clinical role of vorasidenib for the treatment of these tumors remains to be established, especially for those patients who have gross totally resected tumors, whether it should be used immediately after surgery, whether it should be used in grade 3 patients, and in combination with radiochemotherapy. Given the uncertainty in some of these areas, it's important to get input from multidisciplinary tumor boards, but placing the patient's preference at the center of this. As I mentioned, combination studies are ongoing, and it'll be important to understand the mechanisms of resistance in these tumors. So thank you very much.